I'm Shin-Ichi Usami from Shinshu University, Japan. And I'm going to tell you about genetics today. And all of you are interested in outcome of the patient receiving CI, but it is sometimes difficult to predict. We have learned something from genetics, and today, as I'm going to talk about the prediction by genetic diagnosis on hearing outcomes in cochlear implantation. First of all, I will show one example to show you how important genetic testing is. This child's hearing loss was found through newborn hearing screening. Question is hearing loss due to genetic causes or not? Of course, nobody can answer that without genetic testing. But the most common etiology of congenital hearing loss is genetic. This figure shows estimates of cause of deafness at birth and at 4 years in the US. As you can see, the total genetic contribution is 68% at birth and 54% at 4 years. The second question is, his parents do not have any hearing loss. Should we still consider it might be genetic? Answer is yes. Because 70 to 80% of hereditary hearing loss is due to recessive inheritance. Both parents have one allele with a mutation. The children take one allele from each of the parents. And therefore, 1 out of 4, 25% children may have hearing loss. And serial ASSR, auditory steady state response evaluation, suggested severe to profound hearing loss. This patient had homozygous GJB2 mutations, and the parents were found to be carriers for these mutations. He received bilateral cochlear implants at the age of 10 months and 1 year, 4 months. Next question, what is GJB2? What kind of role does this gene play in the inner ear? GJB2 is known to be the most prevalent gene responsible for congenital hearing loss. Encoded protein connexin 26 is known to be localized in the cochlear and thought to participate in potassium ion recycling in the inner ear. A series of reports indicated that deaf children with GJB2 mutations who received cochlear implantation showed good outcomes. I'm going to show one case with GJB2 mutations. As predicted, his language was well developed after bilateral CI. Auditory behavioral development assessed using the Little Ears Auditory Questionnaire showed excellent language development after CI, as you can see in this figure. So now you can understand the benefits of genetic testing. Genetic diagnosis ensures a more accurate diagnosis and suitable clinical interventions based on the predicted phenotype. Next question. How many genes are found at this moment? As you can see in this figure, there has been considerable progress in the discovery of deafness genes over the last 2 decades. Currently, more than 100 genes have been reported for non-syndromic hearing loss. Blue indicated DFNA, which is a dominantly inherited type of deafness, and red indicates DFNB, which is a recessive inherited type of deafness. This figure shows genetic epidemiology based on comprehensive next-generation sequencing analysis. As you can see this figure, GJB2 is the most prevalent causative gene, and the major commonly found gene mutations cause deafness in 30 to 40% of cases. The remaining cases of hearing loss are the result of various rare genes mutations that have been difficult to diagnose by the conventional one-by-one approach. This figure shows a localization of the molecules encoded by deafness genes. The cochlear is composed of various types of cells. The coordinated action of various molecules is essential for normal hearing. A series of studies have clarified the localization of these molecules in the cochlear. When the genetic background is involved in the intracochlear etiology, there is potential for good outcomes after CI. Therefore, it is important to identify the region involved inside or outside the cochlear by identifying the responsible gene. This is our data concerning gene expression analysis using laser capture microdissection. Using a laser capture technique, each portion, spiral ganglion, organ of Colti, spiral limbs, lateral wall was cut out. Extract messenger RNA from the slice and convert it to cDNA. Gene expression analysis was then performed. This is an example of the analysis. This figure shows GJB2 expression in the cochlear. As you can see in the figure, GJB2 is highly expressed within the cochlear. So, good CI outcomes are expected. In contrast, this is an example of the gene expressed outside the cochlear, named PJVK. This gene is, you can see in this figure, is highly expressed outside the cochlear. So, a limited outcome of CI are expected. This is our recent study concerning etiology and outcome of CI. In this study, we evaluated 173 CI or EAS patients. 92 prelingual patient and 81 postlingual patient. To clarify etiology, using a next generation DNA sequencer, a DNA sequencing of 63 target candidate genes was carried out. to discover causative genes. To evaluate outcome of CI, we performed a little years auditory questionnaire for perilingual patients, and we performed the Japanese monosyllable and word perception test for postlingual patients. This is the result. Left figure indicated perilingual CI or ES patients. Right figure indicate postlingual CI or ES patients. As you can see, genetic screening successfully identified causative mutation in deafness genes in 60% of congenital hearing patients and 36% of postlingual hearing loss patients. This is the etiology of the perilingual CI patients. The most frequent causative gene was GGB2. The second most frequent genes were SLC26F4 and CDH23. Further genetic screening by using a next-generation sequencer identified causative mutation in many rare genes, such as OTOF, myosin 7A, myosin 15A, LOXHD1, and PCDH15. 9 patients, 9.8%, were diagnosed with syndromic hearing loss, including Waardenburg, Usher, Down, Noonan, Charge, and Javel-Lang-Nielsen syndrome. 4 patients, 5%, were diagnosed with congenital cytomegalovirus infection, and 1 patient was diagnosed with congenital rubella syndrome. Inner ear muzzle anomalies were identified in 5 patients. This is outcomes of perilingual CI patients using the Little Ears auditory questionnaire. The majority of non-syndromic hearing loss patients with specific deafness gene mutations showed good and rapid development of hearing behavior. In contrast, syndromic hearing loss patient, as well as the patient with inner ear anomalies, showed comparatively poorer and slower development. This is the etiology of the postlingual CI patients. As you can see in this figure, genetic screening identified causative mutations in deafness genes in 36% of postlingual hearing loss patients. I'm going to show you one example associated with TMPRSS3 mutations. This case, a 48-year-old man, progressive hearing loss. This patient had homozygous TMPRSS3 mutations. Okay, this gene is highly expressed within the cochlear, and therefore a good CI outcomes are expected. What is a TMPRSS3 gene? This gene is a member of type 2 transmembrane serine protease family and is expressed in the cochlear, and this gene has been reported to be responsible for DFNB8 and 10. Typically, patients show a ski slope type audiogram and progressive hearing loss. what kind of therapy intervention is the best for him. EAS is the best solution for ski slope type hearing loss. He realized his hearing loss was progressing over the last 10 years. Due to insufficient amplification by hearing aids, he received EAS at the age of 46. As you can see in this figure, residual hearing was well preserved after 2 years post-operatively. His hearing level with the ES was around 40 dB, and a Japanese monosyllable test showed a dramatic improvement with the ES. This patient is very happy with his ES. This figure shows speech discrimination scores of the patient with the TEMPRESS 3 mutations. Pink bar indicate the score of the patient with this gene mutations. As you can see, all of them shows a good outcome after ES surgery. Okay, when a candidate patient for ES visit to a clinic, how can you predict their future audiograms? For ES candidates, hearing loss is more or less progressive. However, it is difficult to predict future audiograms. The speed of progression may be dependent on their etiology. Therefore, we have to think about their future audiogram. If they have more progressive hearing loss, we have to choose a longer electrode. If their hearing loss is more stable, medium electrode will be fine. This is our long-term results for ES using Flex 24. You can see post-operative audiograms and 1 year post-operative audiograms and 3 to 5 years post-operative audiograms. And after 3 to 5 years post-operatively, the patient can be divided into 2 groups. Stable hearing group and progressive hearing loss group. The difference between patients with stable hearing and those with progressive hearing loss in the implanted ear is related to the rate of progression in the contralateral ear, which means natural courses. Actually, we have found several deafness genes in the progressive hearing loss group. So, this is summary of my talk. It is important to identify the region involved inside or outside the cochlear by identifying the responsible gene. Genetic testing is useful for predicting outcome of CI or ES. So now you can understand it is very important to identify the etiology of the patient, especially genetic background of the patient. And we are doing a collaborative study. And if you are interested in genetic analysis, please contact me at this address. So thank you very much for your attention.